Good evening, everybody, and welcome to tonight's discussion. I'm excited to have you guys all here tonight. Kind of nervous tonight. It's one of those discussions that, it always, at least if you guys look online with the post that went on this week, sometimes can turn quite nasty. It gets a little bit contentious. We get folks who get very passionate about some of these discussions, and I think that's admirable. I think it's great that we hold these passions, and of course I'm hoping they're all motivated to helping people, and I'm very confident that 99.9% of the time that's what's going on. But I wanted to come on tonight and just kind of discuss a little bit about the post because it really raised a big hubbub on social media, and thought it would be worth coming on tonight just to discuss the perspective, because I think how the post, social media lacks a lot of nuance. I think if you probably sat down with Christopher Johnson, he's a brilliant dude and he's doing some amazing things around the running game and in his practice up there in Seattle, but I think we'd be able to have a little discussion and probably learn a little bit of the nuance of his discussion, because I think some people are taking those words and running roughshod, saying, making some conclusions and things about it that I think are maybe not 100% there. But regardless, I wanted to, let's see. But before I go on further, I figured, since I might get yelled at, people might get mad at me. No, I'm kidding. But I wanted to have a little moral support on board, so I brought this gentleman. Let's see, where is he? Let me see if I can get him on here. I think I can. Oh, there he is. Mr. Jared Hall's joined us tonight. Yeah. Thank you for joining us, Jared.
Yeah, thanks for having me on, Mark. I'm glad that you wanted me to share the fire that might come your way from talking about a topic like this.
Yeah, it does get a little contentious. Jared and I have both been in discussions with it, and I will freely admit my history with manipulation is I spent my career wanting to become a manipulator and be able to do spinal manips, and thought that was going to be the solution to really fixing people. It was going to be the magical treatment that was going to be, and it definitely has the ability to change pain. I don't think we can argue with that. There's plenty of research to show that compared to other things can do well. I don't think there's anything that's blowing the doors off of persistent pain and anything that's blowing the doors off of long-term outcomes, but spinal manipulation has some solid research when we compare it to usual care that it does pretty good, but a lot of things do, and I don't think it's an amazingly much greater effect. I mean, we can argue there's some things that areas of the body in certain conditions that might have some more beneficial effects for spinal manipulation, but I got to the point where that was my passion and that was my pursuit and practice, and got to the point where I had got fellowship trained, was teaching manipulation, so I'd gone around and taught manipulation a little bit, not a ton of it, because I never really felt like I believed that manipulation was as special as it was. I was exposed to McKenzie practitioners who didn't even put their hands on people and were able to get some similar outcomes. I didn't really see dramatically different outcomes from people who manipulated, people who did McKenzie, people who did other treatments, more maybe Norwegian-based therapies. In the end, I just think we're all doing the same thing, like Lewis Gifford said, and if we could recognize that, we'd probably help a lot more people instead of spending time on social media yelling at each other. But, Jared, what's been and let me actually, before I even get you, Jared, I will also admit that I have been a needling, I don't want to say hater, maybe a little bit of a hater initially. I went through half a needling certification and hated being needled, so I couldn't justify myself needling another human being. So I never went through with it, and I just got kind of frustrated when I saw folks just saying that needling was the cure to everything. I remember seeing some highly thought of, people who teach needling saying, "Hey, if you don't manipulate needle, you're not doing good things. People can get exercise down the street." There was somebody who presented to the Mayo Clinic physicians that was the message we want to be given as physical therapists, and I couldn't disagree with that more. Now, I don't really have any issues with folks needling. It's not my cup of tea. It's not my thing. If within a framework and a process of reasoning and thinking, I think it can be something you can do well and do within a evidence-based framework. But I think what Christopher Johnson was speaking of was a little bit different. But before I get that, Jared, what's been your history with those interventions? I know you've been there, done that a bit with all that stuff yourself.
When I was in school and shortly after I got out of school especially, I felt like manipulation, specifically high velocity, low amplitude thrusts to create joint cavitation or tribonucleation, whichever research you read, was probably the thing that I felt like my program didn't teach me as much as I wanted to know about it. So I immediately set out on the road of taking as many manipulation courses as I could. I think I took something like 5 or 6 manipulation courses my first year out of school. Learning how to isolate down to OA and C1, C2 and the SI joint and specific segmental, manipulations or regional manipulations and, rotational and lateral brake techniques for the uncovertebral joints and everything possible, ribs. And then once I felt like manipulation wasn't doing everything that I wanted it to do in clinic or everything that I hoped that it would, and it was only, seemed to maybe help a few patients, not like my instructor said. I figured it must be dry needling, right? That's the one thing that I'm missing. I need to have the dry needling in here because if it's not the joints, it must be the muscles, it must be the soft tissue. And that's why all these people aren't getting better. I need to needle everything out of them. So I went ahead and took about 5 or 6 more dry needling courses from different institutions because I figured if one institution was good, 3 institutions was better. And I could take all of that information and weave it together to get the best of all 3 of those approaches and kind of needle through the lens of trigger points and needle through the lens of predetermined points and needle through the lens of radicular pathways and combine all those together to come out with maybe Jared's patented blend of needling that focused on, radicular trigger point acupressure whatevers. And then I started doing that to people, and it seemed like I was curing everybody for a split second. And then I realized, what? It doesn't seem like if I do needling or if I do manipulation or if I do that or I do this, it doesn't seem like it's dramatically changed my outcomes. And the people that seem to get the most better with these things are the people that I either tried to really sell it to or that had already been sold these treatments before they came to see me. And then I started looking around with a skeptical eye at other people that I knew that were, appeared to be successful clinicians, and some of them were focused in manipulation, and some of them were focused in dry needling, and some of them were focused in A-stem, and some of them were focused in PRI, and some of them were focused in McKinsey. And I started looking around thinking, well, damn, all of these guys and gals seem to be getting people better. And they seem to have patients lining up out the door to see them. And referring physicians seem to be happy with them. And they have great reviews on their websites. And they tell me that they get everybody better. And it's because of their chosen technique. And I started to think, if everybody is getting lots of patients better and all the patients are happy and all the physicians are happy and all the reviews are good, maybe there's something that connects all these people together that's similar rather than the different technique that they do that they claim is so incredibly effective for them. So then I started trying to look for common denominators between people. What are the things that all of these different super successful clinicians did that made them so successful and made patients rave about them and made them have good outcomes? And it wasn't the technique that they were using. It wasn't the fact that it was dry needling or the fact that it was manipulation or it was A-stem or it was PRI or it was they screen everybody out with the SFMA and figure out what muscle imbalances to treat. It was that they were caring, awesome human beings who had great reputations and spent a lot of time with their patients, and they combined all their interventions with some sort of active care. They tried to empower patients. They tried to focus on what they could do. They built awesome relationships. They had nice clinics that had good environments, and they had good, front office managers. They had everything about everything else that was going on in their environment and what type of person they were and the fact that they did a little bit of this and a little bit of that, but overwhelmingly they got people moving and they encouraged people and they were positive and they built good relationships. Those are the things that I could see were common in between those people, despite the drastically different approaches that they had. And I just realized that you just asked me about my own background, and I went on like a 10-minute rambling spree.
Dude, go with it, man. That gave us some good background of it, and I think you speak to what Corey Blickenstaff, our good friend, would talk about contextual architecture, as far as maybe it's so implicit, I think, with some clinicians and those expert clinicians. But when I've shadowed some of the same type of clinicians, trying to learn how the hell are they so respected and all these things, and you see they are the master of their therapeutic ritual, the story that they tell behind their intervention, the way they execute it, the environment they create around it, the expectations they create on it. Prashant mentions here, does expectation matter in passive modalities? I don't think we can say that. Of course, they definitely do, I think, and that's okay to create positive expectations, but recognize our expectations around our interventions, how you market them to the public, and your messaging and your Facebook ads and your way you portray it to your patients, and how you sell it. And that's okay to sell our treatments, but I hope we, at some point of that treatment care, because in the end we have to move a patient towards their valued activities and their valued life. And if our interventions and our passive modalities are a step in the journey, then I don't really have an issue. Do you have an issue with that, Jared, if somebody uses a manip or a needle to help somebody eventually move past those things towards valued activities and valued living?
No, not at all. I mean, I have a problem with some of the narratives that go along with manipulation or with needling or with some sort of breathing technique that's going to realign the pelvis. It doesn't just have to be a passive approach that has a really faulty narrative. It can be an active approach that has a really questionable narrative that doesn't necessarily make a person feel confident about their body. And I think that the problem that a lot of us fall into is starting to define ourselves by that treatment rather than defining ourselves by the clinician that we are and the clinical reasoning that we have and the ability to screen out medical issues and the ability to enact, behavior change or to create motivation within an individual to change their life, that we overlook all of the other skills, all of the other value that we bring to the table, and we reduce ourselves down to I'm a dry needler, or I'm a manual therapist, or I'm a bone setter. I won't say any trademarked names.
Yeah, don't go there, brother. Don't do it.
I am X, Y, and Z. That is some sort of reductionist viewpoint to subclassify or market yourself or put your self-worth in that is seems like restrictive to me. And you mentioned some evidence, some research on manipulation to say that absolutely it does seem to have some decent benefits when compared to waitlist controls, or when compared to when you add it to exercise as compared to exercise alone. Those benefits seem to kind of decrease in their effect size or their power when you compare to another form of manual therapy. So I think that if in small research studies that a couple of outliers could very easily skew the average data, if we're still fighting to try to justify the super small effect size or the 9 millimeters out of 100 millimeter scale of improvement that this intervention had over another intervention, not to say that that's not meaningful, but is it just noise, or is it clinically relevant, or was it due to those intangible factors about the theatrics that a clinician could utilize when using those interventions with patients, or could it simply be the patient's expectations of said intervention? And there's a lot of what's called the genetic fallacy when you look at things like dry needling and when you look at things like manipulation, because they've been around for a long time. And things like gua sha and cupping and that sort of stuff, they've been around for a long time, and they fall into the genetic fallacy, which is the arbitrary attribution or ascription of meaning or value to a treatment or a person just because they've been around for a long time. So unless we can control for things like that in research studies and patients' perceptions of the meaning and the value that they're going to get from said specific intervention, then super small effect sizes and things that are at the borderline of clinical or even statistical relevance make me want to hesitate to praise them, but also hesitate to throw the baby out with the bathwater as well, right? So I think that we need to be a little bit more humble in claiming a lot of value for certain interventions. And I think that we need to recognize that people are allowed to have their own flavor and their own unique approach to patient care, as long as it fits within a narrative that's positive and a narrative that's not damaging and a narrative that facilitates internal locus of control and doesn't blatantly go against really strong evidence to say that something is either negative or has no value at all, because then it becomes somewhat of an ethical question, and we don't want to go down that rabbit hole.
Yeah, I mean, you said a lot of good things there. I think, as somebody who's defined themselves as a manual therapist in the past, I still use manual therapy, and I've talked on this group many times where I've kind of removed that title from me, because I just think when you spend a career training in something, there's that sunken cost fallacy, and you become identified by it, and then you just kind of live in a world of confirmation bias around it too. You go to the American Academy meeting every year and get that dose of confirmation bias. You go to the same Con Ed and get more of that confirmation bias. And again, it's not to say that it's bad. It's just to recognize that that is not the only ticket to changing pain, especially with short-term pain modulation, which is pretty much what we show manual therapy can do in manipulation. Same with needling. I'm not aware of any long-term effects of dry needling. I could be wrong, but I would have to assume that would be trumpeted from the towers if there was a study like that out, and definitely not anything that's been reproduced. But I just think we get so excited about short-term effects and passive modalities. There's a million ways to do it, and I think if we just swallow our egos and recognize massage therapists are doing it every day, people that do myofascial release probably short-term pain modulate each day, people that cup, needle, scrape, tape. And I don't really, as you put it, I don't really think we need to get so bent out of shape if it isn't our desired flavor. As long as the flavor is moving a patient towards the life they want to live. I think where Christopher's discussion in his post was about when people are so weighted on, I need to be needled, I need to be manipulation, to where it pulls them from their journey into valued activities when they want to be derailed back into passive care. I know athletes sometimes can have a little bit more challenge. They really tend to love, the new shiny tools and things. They gravitate towards that stuff. I don't necessarily have that. I honestly, when people say, "Gosh, aren't you just ruining therapeutic alliance with people? Aren't you ruining your ability to develop, rapport with a patient? Are you losing patients because you don't needle?" I might have had two out of that since I've been in. Well, actually, I think two ever who've said that, if you don't needle, I'm going to probably find somebody else, which I'm fine with. I don't really have any issues. If somebody wants to get myofascial release treatment, I'm not going to say I do that. I'm going to say I do things similar and that can help make you feel better, move better. But if you prefer that exact treatment, I can help you find somebody. But as long as people are using it within a narrative that empowers a patient and doesn't strip them of power, where Corey Blickenstaff, I've been shouting out Corey, I hope he's listening, but anyway, he talks about safety signals, and we had a discussion about this in our mentorship about safety signals. When people ascribe the ability to change or their improvement to something external to themselves, and when we're bringing these passive interventions that are external to a patient into their life, we need to be mindful of that the patient, it's okay for them to ascribe some benefit from it, but if they ascribe their ability to move well and to participate in things only to that intervention, and they can't move forward unless that passive intervention's in their life, then I think we have to be questioning, are we really working in the favor of our patient, or are we working in the favor of our biased intervention? Because we've all been there. And how many of you guys, I want to see a yes on the chat board below here, how many of you guys have been locked in manual therapy jail with the patient where you've been doing the same techniques, changing the pain for the same period of time, and they come back over and over again, and before you know it, you're like 15 visits in and you're scratching your head, having no ability. I don't see any yeses. I think, well, I believe there's a delay here, so I'm going to wait and see if folks pipe in a delay, but I see some thumbs up coming in. Jamie Schwartz, good to have you. Nick Hanna, Ray Allen, Kurt Wessenberg, good to have you guys here. Yeah, we've all been there. If you do manual therapy, you've been there, you've done that, and it's, again, not that it's bad, but again, I think that should make our clinical reasoning and our clinical thinking, critical thinking, peak up like, this ain't cutting it, and we need to move a patient away from it, so that's easier said than done, of course. But the other thing I thought was interesting that you spoke, and I know I'm going off on one of Mark's soapbox tangents as well, and then I'll let you jump back on your box, my friend, but the research settings that we perform these studies, when you have clinicians who are teaching an intervention and profiting off it, or that's their certification or certified intervention, and that's what they're studying, and then they compare it to something else that, for instance, if I'm I am MDT certified, and if I study that versus something I don't really care for or don't really have the training in, like, here's my MDT versus my general joint mob that I really don't care for, and it annoyed me in PT school. There's that thing called equipoise that really the research has clearly pointed that our clinician biases affects our outcomes. And I think we miss that, and we mistake these small effect sizes as, that's all unique to this intervention. Well, I think there's a lot to be unique to the contextual effects and the clinician bias. And there's that Gracely study that Mosley brought out where I'm not going to get into this nitty-gritty details, but it showed that definitively practitioners administering an injection that they had a belief in, a placebo injection that they thought might have some active ingredients, had a much greater effect and positive response from a placebo injection than clinicians who knew it was fake and placebo. So that's just a little 10-second view of that study. Great study to go for. I'll link it in the discussion here to show how clinician bias can affect our research. But with that said, I am just curious, Jared, you had somebody, and we don't need to name names here, but I think you could, if you don't mind discussing kind of that like backlash you received about how you'd rather have somebody not get better and be right than do it. And again, we don't have to get nasty, but I just think it's a good example of how nasty social media can get, and this is a perfect example of cognitive dissonance in action, which I think is worth discussing. Again, we don't have to get into the nitty-gritty details, but I'm just curious what you experienced.
Yeah, so I do want to start by saying that myself and this person had some continued discussion, and it ended in a very mutually respectful way. And I think that part of this was the whole social media miscommunication thing, looking at text, Facebook comments out of good context or without tone or inflection. I think that this person interpreted from me reposting Chris's post and probably some expectations or maybe a little bit of inherent bias that none of us can pull ourselves away from about previous comments or posts that I might have had about the value of manual therapy or whatever it may be, that led this person to interpret me saying something that I wasn't actually saying, and led them to comment back something that I interpreted a little bit different than they were trying to intend it for me to interpret it. So all that to say, there's some very easy miscommunication, and I respect this person a lot, and I think that they're super sharp, and I think that they have a mutual respect for me. So I don't want anybody like trying to figure out, oh man, who's Jared feuding with online or anything. But what it seemed, what was stated to me, or the way I interpreted it, was the fact that I feel the way that I do about manual therapy and reposted Chris's post was basically a statement that me being right and the value of the research that I cite and my beliefs is more important than my patients getting better, and that I care more about my own ego and being right than I do about my patients. And the way I interpreted that was a little bit offensive, because it made an assumption about how much I care about my patients. And I think that if I didn't care about my patients, I probably would spend 20 hours a week outside of just patient care trying to learn more and do better and that sort of stuff. So I thought it was a little bit comical. But to assume that somebody doesn't care about their patients because they don't do manual therapy or they don't do manipulation and dry needling is a really interesting thought process. Or not even because I don't do manual therapy or dry needling, because I actually am pretty highly trained in both and have done both a tremendous amount and still put my hands on my patients every single day in some form or fashion for some percentage of people. It ascribes too much value to these treatments that we're using to self-define ourselves with, rather than as a clinician or as a healthcare provider or as another human working with humans in pain. And we're giving a lot of power to treatments that don't necessarily have super ridiculously strong effect sizes, and assumes that, well, there's just a lot of assumptions, that I wouldn't try some other form of modulation to help a patient get out of pain, or that I wouldn't put my hands on them to try to give them some sort of short-term pain relief, or that I would sit there and tell them that their pain was all in their head, and not do anything to try to buy them some short-term pain relief while we worked on a long-term independence plan and self-management plan to give them ownership over their own health or whatever it may be. And if you don't mind, Mark, I wanted to kind of get off on one more little tangent.
Go for it, man.
I don't want to put any words in Chris's mouth, because Chris was the originator of this whole, multi-share, hundreds, thousands of comments things. But I think what Chris was trying to say is not that manipulation and dry needling are the devil, but what I think Chris was trying to say is that their allure and the way that they're marketed and the way that they're talked about and thought about and revered and pushed within the profession and by certain institutions, and the fact that on a legal level, state associations and national associations have spent a pretty significant amount of money on trying to make sure that we have the ability to do these interventions and that sort of thing. Meanwhile, we're still viewed as a prescription in a lot of settings in a lot of areas, and we don't have good direct access, and we're not allowed to practice to the top of our abilities, and we are not necessarily on the whole super proficient at things like exercise and things like graded exposure, things like progressive overload, things like motivational interviewing, things like behavior change, things like medical screening and that sort of stuff. I don't want to put words in his mouth, but it seemed like Chris was maybe trying to say that because of those things, a lot of the time we're missing the forest for the trees, and it is detracting a lot of clinicians away from developing their clinical reasoning and their critical thinking skills, and causing them again to self-refer or put their value in an intervention rather than in their ability to think and reason and plan and enact behavior change and those sort of things that we know cause really good long-term outcomes.
No, I think you hit the nail on the head with that, and I would agree. I think sometimes we move our focus, and it's been this way since I graduated in 2003, where it's just been the latest, what's the craze of intervention, the next tool that's going to be the thing we can introduce in our treatments to fix people. And I still think we miss so much ability to help so many more people if we could just look past. It's okay to have different intervention approaches, but in the end, the patient should get to the point where they're back to their life and valued activities. And if your intervention's part of that journey and they don't get sucked into a life of passive care and not living their valued life, but they're stuck getting needled and maniped or mobed or myofascially released, whatever it may be. Now, there is argument out there, and we've had some discussions in our mentorship group about, would you rather have somebody getting needled or nipped or, getting injections or spinal cord stimulators or fusions or stuff like that? I think that's I guess I could deal with that a lot better than a lot of doesn't mean that I still think we should just use that as a reasoning to continue to do interventions, for long terms. And, I think we should still strive for that behavior change and internal locus of control and all those things. But we have to recognize we're dealing with humans, man. Not everybody who comes in the clinic is, John, internal locus control, active, motivated individual. But again, even if they're not that way, we should strive and put our 100% effort into to help move them into a direction and at least give them a narrative around these interventions that is founded in science and reality and not in, some of the, traditional dogmatic stuff that gets people believing that intervention is the need. I just had a patient recently who had a hell of an injury and had one of 50 people in the world to get a scapular or a rhomboid reattachment surgery where they're just drilling holes and looping the rhomboid back through the scapular border. It was brutal surgery, but he had all these horrible, trigger points was what he termed them in his neck and different things, and he was just had all this horrible catastrophizing and freaking out and had to move this certain way. He had Googled himself into movement jail because he thought there was only perfect ways to move that he wasn't moving. And when we got him to relax and breathe and do stuff, lo and behold, and he had been trigger pointed to death, and they did wet needles, dry needles, the whole shebang through these muscles. And just one session, I'm not saying this works for everybody, but one session of just learn to relax and stop worrying about moving perfectly and just let your shoulder move. And he said it was like, it's not there anymore. And to me, it's just, again, we could get into argues of mechanism and all that stuff, but I think there is a huge amount of top-down stuff that we don't keep in mind. We still are so thought that it's all about what we're doing at the tissue level, but we've already talked about contextual effects, and we can't discount those, especially when we market and create them. And we have to recognize that we create this culture about people. We can say, well, we're just meeting expectations. Well, stop creating the culture where these expectations are what people think physical therapy is, where physical therapy isn't a needle. Physical therapy isn't a manipulation. Physical therapy is getting people moving or getting people back to their life. I can't remember what's their mission statement. Improving the human movement experience or whatever it may be. I should probably know that. The APTA is going to strip me of my card. But I see our profession still worried about the wrong shit. I'm sorry but we're so worried about interventions. Learn how to listen to a human being, learn how to communicate with a human being, learn how to get them to move without fear, and use some things to help them get there. But let's not make it about us and our interventions. Let's make it about them, the patient. But I think we're still stuck in bitching about interventions and who's right, who's wrong. My research is better than your research, and if you don't do what I do, you're not as good of a therapist as me. I think that's a complete frickin' waste of time, and it's wasting our patients' time and dollars too. And I'm off my soapbox. So anything you have to add to that, Jared?
Man, I just wanted to reiterate the point that I think that it's a hell of a situation that we've gotten ourselves into where we're forced to meet expectations that we don't agree with, that we created. So we have patients that when we see them, they're expecting dry needling, or they're expecting manipulation, or they're expecting gua sha, or they're expecting A-stem, because somewhere somebody has marketed the hell out of it, and they've been told that that's what they need. And it puts us in a position where sometimes we do have to do those treatments if we want to have the opportunity to build a better relationship with the patient and reframe what they think and help the patient cross that same chasm that we have to cross ourselves. And I see more and more people crossing this chasm all the time. I'm super motivated and pumped up to see especially some young clinicians on Instagram, on Facebook, but Instagram especially, just pumping out awesome material and seeing that they have crossed that chasm. It really excites me, because I think that once we can get enough people on board that look at it this way and understand the nuance and realize that sometimes via social media we can't convey that nuance, and realize that, probably if we're getting good outcomes, there's probably 90% of what we're all doing that's pretty much the same, and it might be intangible, and we might not even realize that we're doing it. It might be something that just happens inherently for you, and you just think, man, I am a bad MFer. Everybody that I touch just gets better, and it's because my special super secret sauce. But it goes further beyond that. I mean, I think we can all, most people can objectively watch some John Barnes videos and think this is some kooky stuff, but the dude has a litany of reviews that say that he's awesome, right? But man, he's charismatic, and he puts his hands on people, and he connects with them on an emotional level, and he facilitates some behavior change, and whatever it is. Like I said, I didn't want to call out any patented stuff, but I think that that's a good example of something that a science-minded person would look at and say, "Wow, this is hokey. This is hocus pocus. This is a little bit goofy. This is hard for me to watch." Yet there seems to be, some intangible things there that the research is now supporting via contextual exploration and meaning response and clinical theatrics and expectation and beliefs and biases and all that sort of stuff, that there is biological basis for why people might get better with something that's absolutely ridiculous.
Yeah, and I think science has a hard time capturing the humanity part. It's a qualitative thing, and it's not this nice empirically measured visual thing, people's thoughts and beliefs, yet we know they modulate a pain experience quite a bit, if not a ton. Yet, and I think we're seeing some ways where we're trying to use fMRI studies and different ways to measure nervous system activity, and we're also trying to control for some of these things. I don't know if I just think, and I know Roger Carey and Matt Lone, those guys talk about causality and all these things, and how do we really, is it really realistic in this type of human interaction and trying to help another human being out to just strip it down to RCT? Is that our best way to measure what we're doing with people, when there is a lot of nuance, there is a lot of human interaction, humanity in that situation of another person, caring for another human, trying to help them along, trying to, that establishes, alliance and these things. But we're seeing some of these, concepts of therapeutic alliance and contextual effects and therapeutic equipoise and different things, where we're seeing some of the things external that might be implicitly inside our interventions that we don't necessarily consider. That I think are going to hopefully help us recognize that there's a lot that exists similarly within a lot of different interventions within those contextual things. Like you mentioned with the myofascial release, there's a lot of confident handling and good communication and really handling that painful patient's body in a very rhythmic, soothing way. Same thing with craniosacral therapy. It's one of the more relaxing treatments I've ever had. I don't think my CSF flow got jiggled around any bit, but soothing handling of the head feels damn good. And some people might hate me but I don't think we have great research to show that we have the ability to detect CSF flow and different things like that. But that's getting way off to the beaten path. But in the end, it's all about, if we just strip it to what can help a patient on their journey and make it be about them, I don't think the arguments about which intervention matter as much. It's just like, whatever you use that's your best secret sauce or ability to communicate change to a patient, or communicate the ability to move better and with better relaxation improved pain, then use it. But don't get stuck on it. You don't need to go to every year's national meeting on that intervention. You don't need to identify yourself with that intervention. You don't need to wear a T-shirt on that intervention. You don't need to, get a hashtag or a Twitter handle that's I am manipulation or whatever it may be. But I think that, and I'm speaking from somebody who probably got into that period in my career where I was very much identified with it, and if people didn't feel the same way or use the same treatments, they weren't as good of a therapist in my younger years. But now I realize there are a lot of great therapists using a lot of different approaches who are very much use good clinical reasoning, a good clinical process, and move people to their valued life and goals. And I don't really care if they needle or if they manip or they do anything. I'm tired of us getting excited about those interventions. To be honest with you, they're fine and should be proficient at whatever one you choose to be your mode of changing people's pain. But let's not lose sight of the big picture, the forest for those trees, and recognize that there's a lot more to a long-term change than a short-term intervention. So use it, get over it, move on, get the patient living life again. So any closing thoughts that you have, Jared? I know you're nursing some ribs. You're here you're like on the injured reserve. You came on tonight. Jared took a spill on a snowboard, and he still came on tonight. He's probably not even taking any deep breaths. But with that said, do you have anything else you want to add tonight, my friend?
Well, I was able to just catch my breath. To be honest, I have been out of breath all day. Busted ribs do not feel good, in case anybody was ever wondering. I was just thinking everything that we have been talking about over the last 15 or 20 minutes or so regarding context, regarding human interaction, regarding expectation, so on and so forth, they're the best example to prove how important, to show how valuable that stuff is. The best example that I could think of is a research design called the open hidden paradigm. And I don't know if you guys out there are listening are familiar with the open hidden paradigm. If you're not, look it up. Read some of Fabrizio Benedetti's work on the open hidden paradigm. And in a nutshell, what it is the comparison between giving a patient a well-known, efficacious treatment in an open setting where the patient knows that they're receiving the treatment, or a closed setting where the patient doesn't know when they're receiving the treatment. They know that at some point they will receive it, they just don't know when they get it. So one of the best ways that I've seen this studied is in acute postoperative pain. And the patients knew that they were going to get a shot of opioid-based painkiller. And we know that in acute postoperative pain, opioids tend to work pretty damn good. They have good efficacy. There's no arguing that unless you're one of the genetic difference, the people that are genetically different that don't respond very well to opioids, but that's a small percentage of the population, a smaller percentage. And they set up the study to either have a physician come in and inject that opioid directly into their IV pole, or to have a machine set up to administer the dosage of opioid pain medication at a random time interval. And what they did was then they measure patients' reports of pain and how they're feeling. And the medication has 50% greater efficacy when administered by another human being than when administered in a hidden setting where they don't know exactly when they get that medication. So if you have a 6 out of 10 pain and you don't know when you're going to get the medication and your pain goes down to a 4 out of 10, and you do know when you get the medication, your pain will go down 50% more than that just by a doctor coming in and injecting it into your IV pole. Not a lot of interaction, not a lot of talk, not even a whole lot of chit chat, not even a whole lot of physical contact. So now let's amplify that by a treatment ritual. Let's amplify that by human interaction. Let's amplify that by asking you about your kids, saying that you look good today, Miss Jones, cracking a little bit of joke, get a little bit of a endorphin release, a little bit of serotonin, a little bit of dopamine in there along with some opioid pain medication or whatever your secret sauce treatment is, and start to imagine what the efficacy or the added value of that interaction is when you look at in the open versus the hidden setting. And this isn't just in pain. This hasn't just been studied in the experience of pain. This has been studied in people with Parkinson's disease as well. And they have significantly greater efficacy of the administration of dopamine. And even when you give placebo dopamine to, or I guess a placebo thing that's supposed to be dopamine, to people with Parkinson's disease, a very objectively measurable dysfunction in the substantia nigra and the basal ganglia, right? And yet you get significantly greater effectiveness of the administered dopamine when it's given in an open setting versus a hidden setting. So it's really interesting, and I think that we need to step back and just really examine where the value in our treatment interactions is coming from. And it's coming from a lot more places than just the specific treatment. Not saying that it's not coming from the treatment, but there's a tremendous amount of that value in the entire treatment ritual that is multifaceted and really complex.
Yeah, no, I think, we got to recognize that we create the meaning around our interventions. We, not only us, but, the patients have a lot of experience in their life that have preconceived meanings, and we could get into predictive processing, which we will in our mentorship call on Wednesday, but for now we won't get too into the weeds of that. But we have to recognize, and it might help to talk to the patient, understand what their meaning of that intervention is, what they think is, what's their mindset around it, along with trying to really use the context, leverage a context around your intervention to kind of sell it and to produce an environment where interventions will be likely to be more effective, but recognize that's a part of it, and not, I think too often we just want to make it all about our intervention and don't recognize that there is that ritual that surrounds it that often is a massively powerful driver, which you nicely pointed out in that open hidden paradigm, which obviously probably can't pull that off in manual therapy trials, but it is a good example of how that ritual is very important, even though there wasn't much of a ritual in that study, but I think I remember the one you're speaking of anyway. Well, all right, sir, I'm going to let you have a good rest of your night. I know you got to probably take some ibuprofen, let those ribs quiet down a little bit more. I hope this discussion was helpful for you guys. We didn't yell at each other. We didn't say anybody was mean or stupid or anything like that. Apparently you can talk about these things and not get mad. I applaud Jared for how he interacts on social media, and I don't even know who the gentleman or woman was who had the discussion with Jared. And I'm not trying to stir up any social media drama myself, so I apologize if anybody thought that was the case. But it is nice where people can actually have some disagreements, talk back and forth, and it doesn't need to be mortal slights and people getting so defensive. But again, if it's all about our patient, we should be willing to open our practices up to critique, especially if it's all in the best interests of helping more people and improving ourselves. We improve ourselves by listening to some of the experiences of others and learning from the experiences of others. So with that said, I'm going to let you guys have a great rest of your night. I'd love to hear your feedback on the talk. If you have any questions, put them in the links below or the comments below. We'll try to touch on them in the thread. You guys have a great rest of your day. Have a good night.